Good afternoon, everyone, or good morning in Australia. This is Dr. Sean Paul from Austin, Texas, and today I'm going to talk a little bit about radiofrequency facial contouring. We also have a live patient here in my office who is ready to receive some of the treatment. So we'll switch over to the PowerPoint slides and get started, and then we'll show you some of the treatments that we're going to discuss today. So I'm an oculoplastic surgeon here in Austin, Texas. Here are some of my Instagram and social media handles. I also want to thank the speakers and conveners for asking me to present. I've seen them in Austin and Australia. I hope to get back to seeing you in person really soon. So the objectives today are going to be to describe and share some of the innovative eyelid and facial treatments that we've added to our cosmetic treatment offerings, share cases of radiofrequency treatments with combination adjuncts, share early results with these patients, and discuss the learning curve of procedures, and also then have a live demonstration. So a lot of us have experienced this in our clinic. Patients want an aesthetic surgical-like option with less downtime, and figuring out if this is possible around the eyes, faces, neck is something that we've strived to do here in Austin. So my prediction is with this influx of technology and cosmetic physicians need to help one another to create better outcomes. And while this is exciting, guidance is needed. So there's been recent publications about using radiofrequency to treat this gap patient for soft tissue contouring. This has been demonstrated nicely, as well as the part of what we're going to talk about today is and these minimally invasive treatments, patients' alternative aesthetic face options, particularly from an ocular standpoint, considering patients who are non-surgical candidates or Blepharoplasty, such as Evoke. Remodeling treatment. Essentially what that means to the skin, remodels it, neoelastogenesis, and regeneration. Very safe technology. Second, controls that temperature. There's different applications, and these two areas specifically that we use. Make sure it's not on social media and just. Now, you just want to make sure that they're positioned well. Larger faces out. Typically, thicker skin. A maintenance session of months. From thermal profiling, you can see how the skin is and the tissues below are heated down to the fibroseptal network, which creates long longer contraction and tightening in that area. And then you can see the follow-up results. Here's some of our cheek to profile without something surgical. You can also see they have a nice contouring. Again, there is no contacts. This has been really great during the pandemic for patients who do not want anything invasive at all, that want to come in a socially distancing friendly environment. And for patients who just want to improve their jawline and do not want to have something invasive whatsoever. So again, nice contouring, improving results as you progress through the follow-up treatments. And these results last, which is really, really nice. Now, I'm next going to move our discussion to the minimally invasive options that we utilize in our practice: AccuTite, FaceTite, and Morpheus, the RF microneedling. It's really been amazing to see over the last 2+ years what we've been able to achieve with non-excisional surgery. In certain areas, we're able to use a lipolysis portion of this device, which essentially heats and melts fat, particularly underneath the chin, to improve contour. And other areas, we're able to contour tissue underneath the eyelids, around the neck area as well, to give a better texture and tone. And you may be wondering why, we want to do this, or why we want to not do something surgical. And again, it goes back to that gap patient wanting to tweak, wanting to have minimal downtime, wanting to use certain temperatures as a physician to give your patients options to remodel fat, tighten skin, and areas that we've tried have been lower lids, brows, submental, fat and loose skin, smaller areas as preauricular area of loose skin, areas above the nasolabial fold, areas of prior fat grafting, neck rolls, bra roll, bikini roll. And really, when you talk about this combination, external heating plus internal heating, there's a family of products here. The BodyTite is for larger areas, FaceTite is really down for the neck, and the AccuTite is the most precise and smallest treatment. We combine this or use separately the same technology, radio frequency heating onto the skin, to create deep fractional technology which penetrates up to 4 millimeters, and now in the US about 7 millimeters on the body. But we're not trying to that, we're trying to contour the skin and capture film. So this has little to no thermal damage to the epidermis, decreases the plume or risk for spread of plume effect, and also can contract tissue where you need to decrease stretch marks in the neck or other areas in the body, such as cellulite. And this is a good little cross section of how deep these treatments go. And what I like to show here is that you can really customize by your patient and their texture and tone of the skin exactly what you need to do. There's no scalpel needed. There's no incisions. You can inject essentially subdermal heat. I've compared this in the cadaver lab versus more traditional cautery systems. This is much lighter. There's no aspiration needed in certain areas unless you're using a certain volume where you would need to aspirate, such as in very full necks. And you can really customize underneath the dermis where you want this contraction to happen. And what you'll see is gentle changes in the skin, improvement in the texture and tone, because this induces neocollagenesis. So I think the future of aesthetics is really going to continue to change. Of course, surgery is still the gold standard, but some patients want options, and as physicians, I think we want options as well. So I compared this new technology as when I first started to learn eye surgery many years ago. There's a machine in the room, it makes noises, there's a screen, it took me time to learn this technique. Training does take time and effort, and RF or radio frequency results take time. It gets better with time, it can be frustrating, but it does get better. So begin in safe areas if you're going to bring this technology into your practice, pre-counsel patients, spend a lot of time with them, and encourage them. Results are not instantaneous, but will improve. And we talk about the periorbital tissues. It's important to note that you want to stay underneath the muscular area so you can contour the tissue. You want to be very cautious to make sure your patient selection is correct. There's many critical structures around the eye. So of course you do not want to, you want to stay in safe areas such as fullness underneath the lids and the festoon areas. And you want to mimic a lid tightening procedure without the need for an open surgical procedure. So I think of the lids in basically 3 layers, although we know there are more layers here, but skin and the redundancy amount that we see in the tissue, the muscular tissue, as well as the fat. And you're creating a pool of heat in that area that's very safe, that's gentle heating, and can shrink these tissues, tighten them, and particularly when the lateral canthal tendon's intact. And it's important to educate patients that this is a good in-between step, and as you'll see in some of our before and afters, can lead to complete improvement in the area. So our criteria for periorbital rejuvenation are patients in the ages of 25 to 60, mild to moderate fat herniation in the lower lids, no lower lid laxity, and no prior blepharoplasty. And here's a little cadaver dissection video I showed about the anatomy planes here. So here we reflected the skin and the muscle. You see the orbicularis oculi there. And we want to describe to you exactly how we're going to approach this area. And it's important to note that as you reflect that orbicularis back and show the SMAS as well below, that there's the wispy septum there and the fat posteriorly. And our goal again is to heat the anterior lamellar tissues, tighten them, provide contouring, and not enter the retroseptal space. So we're demonstrating the device here, and you'll see it here live shortly as well. We place ultrasound gel over the skin. We tent up to make sure we're not too superficial. And then we gently provide heating of this tissue, improves skin contour, texture, tone, and the procedure takes about 10 to 15 minutes in the office under local anesthesia. Just for demonstration purposes, we flipped the skin back here. We demonstrated the bipolar cautery-like effect of this area, which leads to neocollagenesis, tightening of the skin in a safe fashion. So, case studies here. Here's one of our patients with a 90-day post-op with lower eyelids only. She had had combination upper lid surgical blepharoplasty as well. And it showed that we can really contour the lower lid without the need for filler, without the need for surgery, without the need for laser resurfacing. Older patient as well, another 90-day post-op result. Lower eyelids only done with radiofrequency, upper lids were done surgically, and again combined with the AccuType procedure plus the Morpheus radiofrequency microneedling. And of course, this isn't a complete result. Certainly she could have used some laser resurfacing to improve texture and tone. She could have potentially used a little bit of filler or even a surgical blepharoplasty, but to not have a surgical procedure done underneath the lids, she was very, very happy. On this patient here, I'd actually done her I had performed surgery on her older brother. I performed fillers on her older sister, and she elected to go down the middle toward radiofrequency. And she had a combination of AccuType plus radiofrequency microneedling. It improved the texture and tone underneath the eyes. Still some periorbital hollowing here. Potentially could use some filler, but a satisfied patient. Next, a male patient who really didn't want to have any surgery whatsoever, but wanted to improve the appearance of his under eyes as well. He also has French Canadian ancestry and a executive at a tech company here, so didn't want to spend the downtime from the general anesthesia and wanted to still do some contouring here. So obviously, this is kind of leads into discussion of festoons and pigment issues around the eye. And I think our patient was very happy with his result at 90 days. And you can see here the contouring is improved. There still leaves a little bit desired there, but these are tough lids to perform surgery on, and many of our oculoplastics colleagues and facial plastics colleagues would definitely agree that these lids just by themselves would not be something easy to do surgically. This was just to show and demonstrate lower lid Morpheus alone, or the radiofrequency alone. This is something that we occasionally delegate to our nursing and esthetician staff. He also had a surgical upper lid blepharoplasty. This was AccuType plus Morpheus to the lower lids with the surgical upper blepharoplasty. And you can see here as well, just the crepey skin that's really hard to improve with fractionated laser, with the downtime of fractionated laser. You just don't see that with the radiofrequency. Here, neck improved. We also used a suture suspension for the placental bands and improved the contour of her jawline. Really happy with the patient's results. The jawline, she also had her under eyes done with Morpheus. Another patient here with submental AccuType plus Morpheus to improve jawline. This is an early result at about 3 weeks. So post-operatively, we have compression in those areas. We use the lid goggle around the eyes. We use a compression device around the neck, and we avoid UV light for 1 to 2 weeks. So I'm going to head over now to our patient and demonstrate in live fashion. Our patient's been very patient, doing well. The AccuType around the jawline, as well as the under eyes and the Morpheus on the neck. On the lower lids and the jawline. You can hand me an 18 gauge needle. I'm going to move the patient over here just slightly. And close your eyes for me. So we've already pre-marked the patient here on the submental fullness with this ciatoblepharon. I've marked the eyelid crease at 3 millimeters. And all you need is an 18 gauge needle. Make a small needle poke, just about 1.5 centimeters lateral to the lateral canthus. Directly poke in a submuscular fashion. And there's already ultrasound gel, but I'll have my assistant apply additional ultrasound gel. We've put the temperature at about 40 degrees external and 60 degrees internal. And I'll take a 4x4, please. And just put a slight bit of retropulsion on the eye. And you'll just enter in your area there. It slides in nicely. And you can tent up just to make sure you recognize you're in the right area. And then you'll start to hear some beeps here, and these beeps demonstrate the amount of pressure, the amount of temperature on the eye. And you can slowly heat across the lid. The triple beat means you've reached temperature. And you want to go in a retrograde fashion. Go down a bit further here. This can also improve the blunting of the tear trough as well, which we've seen in some of our patients. And again, these results are gentle contouring to tough areas. So patients who have that crepey skin or early acetoblepharon, are averse to filler, or don't want to have the downtime for laser, and want to have improved contour underneath the lids. Once you hear that triple beep, you do not need to retreat the area. I like to treat laterally as well, improving the tightening of the lower lid. I do not do patients with any lid laxity pre-existing. And then what you'll see is gentle tightening. So that's the lower lid AccuTite. And next we'll demonstrate the same treatment here along the jawline. So we made a small stab incision just underneath the ear. And instead of doing like a short scarf facelift or a lateral lift, you can actually tighten that tissue in contraction and add contraction gently. And what you'll hear here is just a little bit of noise, and you'll hear the skin start to contract gently. And again, you're inducing neocollagenesis, which takes about 10 months. You're not going to see immediate results. But a lot of our patients like the fact that they get the natural appearance with essentially no scars. And you can see it doesn't take very long to do. And when my patients ask me how much percent they can expect improvement, I typically say between 20 and 40%, but I've had upwards of 50 to 70% improvement as well. It just depends on the patient. And you can direct down as well laterally and inferiorly. Now, I didn't own a single device in my practice until about 2.5 years ago. Can you switch this over to the Morpheus setting, please? And I think it's really important to understand the way that the mindset's changing of patients, where they don't want surgery all the time, but a lot of times we don't want them to walk out of the office with having no options. And you go to 20 there. So I think Morpheus has been really helpful because this is something that you can do under local anesthesia, under topical anesthesia in the office, requires minimal to no downtime, and you're able to treat. I really like Morpheus for deeper lines on the face, around the eyes for parietids. Patients that are tired of getting Botox want another option. It's a great option too. And you can see here, you can do multiple stacks. We're all very familiar with other microneedle devices, but the fact that you can add heat to this as well and create that subdermal contraction has been fantastic, particularly in hard areas to reach. So there's 3 different tips that we use, particularly around the eyes, but also in the neck. One goes down to 4 millimeters. One, and that has 24 pins. That's what we're demonstrating now. There's one that has 12 pins, which is called the Morpheus Prime. That's for fine lines of wrinkles around the eyes. We like that quite a bit. And the last one is called the Morpheus Resurfacing Tip. That's been really nice for a non-ablative 500 micron resurfacing feeling around the eyes. So if you already have your InMode device out and you're using it, and you don't want to use an additional resurfacing laser, or the patient doesn't have the downtime to have an ablative resurfacing, it's a great option for them. So essentially right now we're treating down to 2 millimeters. We're doing a triple stack, which means we're going 3 times in each area. And we're able to cover the entire neck here. So all in all, these procedures are safe, they're effective. I think the learning curve that I've had on this is making sure you set expectations correctly. Always leave surgery as another option. In addition to surgery, I think people want options, and a lot of times heating the tissue is a great option that's safe. All right, so we'll switch back over to the PowerPoint there. So we'll do the picture now. So in conclusion here, I think Knowing your anatomy of the lower lids and the neck has been really important when adding these new procedures to my practice. In particular, if you're trying to get really nice results, you want to know the layers that you're treating, as well as understanding where radiofrequency can be a safe alternative for treatments for patients with dry eye or filler reverse or laser reverse. Preoperative assessment is critical. And so I think if you explain to your patient why this could be an option for them, not only may they not choose this treatment, they may decide to go with surgery, but they may choose it and actually be able to benefit aesthetically and be able to treat themselves something they want to do and have an option that's within a reasonable point to reach aesthetically as well. Surgery just isn't for every patient, although a lot of us make our living, have made our training on it. I think it's nice to have the full spectrum offering in your practice. And I think you want to clarify this is really skin tightening and it takes time. It's not surgery, and surgery is different where you're really trying to correct or overcorrect and then things settle down. This is more of an infusion of heat and tightening its contours of skin and more of a facial contouring standpoint. It doesn't need to be repeated necessarily like injectables do as well. It depends on what degree of treatment you're doing, but it depends on what treatment, what kind of results the patient really wants. There is some downtime with this, so they don't have the true surgical downtime, which is going to be the swelling and the lifting restrictions and things like that. But they're going to have some of the bruising and swelling. So socially, they may plan for about 2 weeks of avoiding dinner parties. Not that we're all doing dinner parties right now, anyway. And then finally, I think, again, leaving surgery is your next step, if not combined. But I just want to do a takeaway here. When I was in Australia 3 years ago, this was just something I was starting to get interested in. But there's no doubt radiofrequency works. I think the technology continues to get better and better. And if you use the spectrum of technologies, whether it's the non-invasive, such as the Evoke around the face, there's also a treatment called the Evolve, which is around the body. The face type, the body type, and the AccuTite are a little bit more invasive. And kind of the in-between is the radiofrequency mic.
We've got some of our panel here. We've got Dr. George Marcells, Dr. Simon Taylor, and in Melbourne we'll shortly have Dr. Peter Callan. Oh, it's actually Benjamin Bird at the moment, but I'm sure Peter will be around. And then from our overseas guests, we have Sean Paul, who's staying on the line. Robert Goldberg and Michael Groff has joined us as well. Guys, thank you very much from Saturday morning. It's a beautiful sunny day here and on the harbour in our studio here, and we thank you very much for making some time. I'd like to ask the viewers to send in some questions while we've got our speakers live, and we'll get to them as often as we can. But I'd like to start off with you, Bob, and ask you a question. You've probably had the most experience with hyaluronic acid gel fillers around the world, around in the periorbital area. Are you seeing some problems 10, 12, 15 years later with the swelling that some people like Greg Goodman and I think Rebecca Fitzgerald are starting to describe now? I know your connection's a little bit patchy, but we'll persist and see if we can get through it. Over to you, Bob, if you can hear me.
I can hear you well, Angelo. I hope that you can hear me. I think Australia got, because of all of your cyber crime, I think, from our internet in the United States. That's why I couldn't log on. That's what UCLA told me. But Angelo, we just published, Danica and I published our, I think, 13 or 14 year results. And there is a group of patients that develops swelling. In our study, it looked like it was around 10%, although the study, it wasn't designed to get an accurate range. But in my anecdotal experience, I think about 1 out of 10 patients after 10 years end up getting the filler dissolved. But on the other hand, 8 or 9 out of 10 of the patients in our series were doing very well. And one of the interesting findings was that, especially if they had had maintenance for the first 3 or 4 years, they were needing very little filler. It almost looked like they were getting some permanent effect. So the frequency of requirement for maintenance seemed to go down and down. So to summarize, there's that some patients develop late fluid or some other issues, the blue-gray dyschromia, or the orbital ridge of filler that you see sometimes, that limited the use, but most didn't. And the final thing I'll say is that what we have found, and what other authors have reported as well, is that in that group that's unhappy, they still tend to do pretty well by dissolving the filler with hyaluronidase and then starting over. And I think it's even a smaller group that has some problem related to the filler.
Thanks, Bob. I'll hand over to Dr. Simon Taylor now, who has a question for Michael Groth.
That's right, Dr. Groth. In terms of, you were discussing lower lid patients with some lateral canthal laxity. Could you tell us what suture that you like to use? And for the ones with even increased laxity, do you ever manipulate the orbicularis muscle or tighten it up? Do we have an audio problem?
I think, Michael, we're not hearing you at the moment, but we'll get there.
Probably Groth didn't push the button on his computer.
I think it's those Russian hackers, probably, Bob.
Yeah.
I guess that's probably the only way that you can explain that election result over there, I would think. But
Can we hear you, Dr. Groth?
We can't hear you, Mike. Mike has to put his mic on.
Have to check the mic, yeah.
That's right.
Bob, can I just ask, with those patients that do develop fluid from the fillers, have you found that responds well to hyalase, or do you find that sometimes it doesn't work?
Right.
Of course, there's always, there's that small group where the hyaluronidase doesn't seem to improve it. And by the way, my suspicion is in those groups it may be multifactorial fluid, right? Maybe there's some rosacea or some other features in addition to the hyaluronic acid, to the hyaluronic acid. But the overwhelming majority, in our experience, respond to hyaluronidase. The filler that we use, Restylane, it turns out, probably is one of the fillers that dissolves the most reliably with hyaluronidase. Some of the other fillers may be more difficult to dissolve, Juvederm, for example. But even in those cases, I find, at least with several episodes of hyaluronidase, I can, in the vast majority of the cases, get rid of the fluid problem with the dissolving agent.
Thank you.
Thanks, Bob. Sean Paul, can I just ask you, in those patients we were just talking about with Bob then, do you find the radio frequency might be good at helping resolve some people who have that fluid collection or gathering, edema?
That's a great question. I know that Galderma's studies, test fillers at very, very high temperatures, and some of the initial thought was that radio frequency could dissolve some of the fillers if it was injected periorbitally or in other areas you want to get rid of it. We really haven't seen that clinically. We tend to still use hyaluronidase to dissolve it before we treat, whether for blepharoplasty surgery or for any of the treatments that we discussed today. I do think it provides a nice alternative to patients who want periorbital rejuvenation, who've had a bad experience with filler around the eyes. Particularly, there are a lot of studies coming out about the lymphatics around the eyes. Now, certain filler products, not the ones that Dr. Goldberg uses or that a lot of us use, but other ones have also shown some obstruction of the lymphatic system around the eye that can lead to chronic periorbital swelling. So I just think it provides a nice alternative for sure, but I haven't seen a direct correlation with RF dissolving the filler.
Thanks, Sean. One of the questions that's always been difficult for me to answer is, I think Mike showed some great photos there of a skin festoon where you have a little bit of excess, and I think those do really well with direct excision. Sometimes you see younger patients who may have familial type of, perhaps we can, the terminology changes, but we can call that perhaps a malar mound, or there's really no excess skin, but there's a little bit of fluid. And I've always thought that perhaps some non-surgical devices would be useful for that. So I'd like to ask first, Sean Paul, whether the radio frequency, perhaps that the needling tip is useful for those younger patients that seem to have a malar mound or a festoon. And then in our Melbourne studio, I'd like to throw to our team there to see if they had a question for one of the speakers. So Sean Paul first.
Yeah, this has been an area of excitement and possibility whenever these treatments came out for the periorbital region. There's been some initial presentations done with other radiofrequency devices with microneedling that have graded out the severity of festoons going from severe to mild and seen 20 to 25% improvement with repeat treatments. I think it really depends on understanding the histology of what a festoon is and the coning of the muscle as well as the fluid retention. Certainly a direct excision, I think, is a gold standard. We've seen some really nice results with some deep laser resurfacing, but there's a lot of downtime and risk for other adverse events when you do a deep laser resurfacing. I certainly think if you have the right patient from a selection process that we have seen, and we've seen this already happen with sequential treatments of radio frequency at the right depths of varying between 4 millimeters, 3 millimeters, 2 millimeters, you certainly can get a long-term tightening. Now, how long that's going to last, I'm not certain. I also know that you're going to get some periorbital swelling after those treatments because the periorbital area is rich in vascular structures. So I think there's a lot of potential. I think this is a tough area for patients who are desperate and don't want surgery. This is what we're offering our patients here.
I think we have Mike Roth back on the audio.
I don't think so.
Oh, no,
Yes,
you're good, Mike.
We're good, we're good.
Oh, good? Okay, great.
Now, just before we cross to Melbourne, maybe I'll ask that question again. In terms of supporting the lateral canthus, what suture do you like to use for lateral canthopexy?
Well,
and do you ever manipulate the orbicularis muscle?
Oh, that's a very good question, Simon. It depends on how loose they are. There are some people who have just mild laxity, in which case I generally use a 5-0 Vicryl, 5-0 PDS. People with more profound laxity, where I have to reattach a tendon, then many times I'll use a permanent suture like a 6 or 5-0 Proline. And in addition, I rarely do much with the muscle. My experience is that orbicularis resuspensions I only use for basically non-aesthetic cases. Many times it will change the animation around their eyes when they're smiling and whatnot. So I prefer not to use any suspension of the orbicularis in that setting.
Mike, fantastic results as usual, especially the longevity of those brow lifts. I was interested in your ability to remanipulate the brows, if you thought the position was wrong. When you're doing that saline injection, how do you know you're actually subperiosteal and not just subgaleal?
It actually becomes very obvious. The surgical plane that you made at the time of surgery, when you direct the needle down to the bone, you can inflate that compartment, and then you can hydrodissect. You create like a little bleb about the size of an egg, and you can just massage it around the forehead, and you hear it pop, pop, pop as you move the fluid in that plane. It becomes really obvious that you're in the correct plane.
Right. And can I just also
It basically floats. Sorry, but it basically floats the soft tissue flap off the bone and allows you to reposition it.
Okay. Can I also ask, with the screw technique that you use, when you take it out, do you actually close that incision? Do you ever have problems with hair loss or the scar in that area?
Rarely do I have problems with hair loss. Screws. I've used endotines, I've used screws, I've used bone tunnels over the last 25 years. I find that if I have a good release, there's very little tension on the follicles, and so there's very little in the way of hair loss. In addition, if you put the screw in the most posterior aspect of the incision, the entire weight of the brow is suspended on the screw itself, and it's distributed very evenly. If you try to use staples behind the screw, there's usually an area of pressure that's very small that creates localized loss of hair.
Gotcha. So over to Benjamin and Peter Callan. You have some questions there you'd like to go through.
Two important questions, Bob. Great to see you in Los Angeles, and it was a wonderful speech. Peter's got a question about the type of camera that you're using after the 2017 meeting.
Well, this was just for the end if we ran out of time, Bob, but the RX100, have you upgraded from the Sony RX100, the best camera that you've ever had? I don't think we're getting audio feed, are we?
We
Can you guys hear us there? So, Professor Goldberg, there was just a question about the camera you're using for your facial photographs.
I think Bob's frozen.
I don't think.
I think
I
Bob's
don't think any of
blinked.
you can hear it.
Maybe his audio's a little bit out. But we had a question here which is interesting. We've got a question from Tony here. There have been a couple of cases in the media with filler and COVID-19. Can you...
That vaccine.
Oh, the vaccine. Yes, the vaccine. Yeah. That's right. It's caused some swelling. Now, I know there's probably only 2 or 3 cases, but Bob, if you can hear me, give me a wave, and then see if you can answer that.
Yeah, it's interesting, and we're getting a lot of calls from patients asking about that exact issue. The cases that were reported were in the clinical trials for the vaccine, and there were patients who'd had previous fillers, swelling. All of the cases, I haven't seen the cases myself, I've seen summaries of them, so this is a little bit of hearsay. But the hearsay that I've heard is that these cases were generally self-limited and responded to the standard treatment for swelling. There have been no cases of permanent issues related to the fillers. And Angela, you must have seen it from time to time, even when patients get a flu vaccine or any kind of systemic allergic or autoimmune reaction, the filler in some patients seems to be an antenna that picks up that autoimmune reaction as sort of a bystander or something. And so my interpretation is that's what this is. And when those events happen, they almost always respond to antihistamines or steroids. I think it'd be very unusual for a patient to get such a bad reaction that the filler would have to be removed. And I think it's practically impossible, hopefully, that there would be such a severe reaction that it would lead to permanent complications. What we're telling patients right now is that they should wait 10 to 14 days after they get the vaccine before they have filler. And frankly, I think that's just PR, because I'm not even sure if that makes that much of a difference. That's about the best way I can answer that. We're all paying attention to see if there's more cases, but to my knowledge, unless some of the other speakers or participants have heard, to my knowledge, there haven't been more cases reported since those that showed up in the initial trials. Has anybody else heard about new cases? It'd be very interesting.
That may well have been a little bit of fake news as well, probably, Bob. But so I wanted to ask Michael again. Many of the speakers that we've had, and Guy spoke a little bit about it, and Warwick Nettle spoke about it yesterday, use a lot of autologous fat injections around the periorbital area in the face. Tell us about your experience with whether you do that, or whether you found that useful, or whether you think there's a need for that.
Well, that's a very good question. I think there is a need for volume augmentation, volume replacement. I generally don't do much of it. I usually refer that out to somebody who does that. I think it's more precise when it's done at a separate setting, not at the time of the procedure. And I don't do a lot of fat grafting only because it doesn't work well in the periorbital region in general, but it does help to inflate the brows and temples. And that actually is a good use for filler and or free fat grafts. But I generally refer those out. I'm basically a surgeon. I don't do much fat grafting or fillers.
We've got another question here for
Angela.
Dr. Sorry, please go on, Professor.
Bob, you can speak if
Oh,
you'd
I was
like
just
to.
gonna, Angela, I was just gonna comment on the fact because I have had a lot of experience with it. And, obviously this is not new. We did a fat study. I was a fellow, and that was, I think, more than 5 or 10 years ago, wasn't it, Angela?
Probably longer
So
than that.
it's been around. It's been around for 30 years, and it goes in waves of enthusiasm. And I think those waves are interrupted by someone having a miserable patient. And then you lose your enthusiasm for 5 years until you forget how unhappy that was. When fat works well around the orbit, it makes for very beautiful pictures in your lectures. But the 1 out of 10 or maybe even 1 out of 20 cases where you get a problem, the problems can be really severe. Some of the most miserable patients I've taken care of in my practice are patients who are unhappy with fat grafting because they get irregularities or nodules that for some reason psychologically overwhelm them to be out of proportion to how bad they are. I've had that experience again and again. And the problem is it's just unpredictable. You don't know who's going to get an irregularity or a granuloma. They're very hard to deal with once they happen. So one thing I would at least suggest for people who are starting out, start conservative and select patients carefully, because I think there's always going to be those unpredictable results. And I've seen them from the best self-proclaimed injectors in the country. So I don't think anyone has figured it out so perfectly that they can avoid these problems. The good results are good, but the bad results can be really bad. And I'm in my cycle, I'm in a skittish phase right now where it makes me nervous. Like Michael said, in areas where there's better protection, the brow, the cheek, I think it's good. But thin out of the skin, just got to be careful.
Yeah, I think you make a very good point. And what I try and teach the fellows and people starting out is whatever procedure or operation that you're doing, one of the most important things is that if you do get a complication, and we all do, you got to try and make sure that it's not that bad and that it's fixable. So do a procedure or do an intervention where if it goes wrong, you're not in such a bad position. I think that's really important. But Stephen Liu, a plastic surgeon here in Sydney, has got a question for Dr. Sean Paul. And I had a question as well. When you put the Accutite needle into the lower lid, Sean, how do you know that you're just in front of the septum? Is that, so you're just underneath the orbicularis muscle in front of the septum before you engage the energy? Can you take us through that? If you can hear me, give me a thumbs up.
Yeah, I think that's been one of our challenges, and we had to go back and forth to the cadaver lab multiple times to describe that plane. We've had multiple doctors attempt to use Accutite either just underneath the skin or in a more dangerous plane behind the septum. And I think that essentially if you feel the pop of skin and muscle are able to direct into a surgical plane there by creating basically a hydrodissection with the local anesthesia, you can safely get into that plane. Now, is it 100% foolproof? Certainly not. I think that you can go one way or the other, but I think the most important thing is not to direct retroorbitally or post-septal. And again, in that nice gliding plane there, you can feel, and that's why you can put the tongs together there and feel the thickness of the tissue that you're holding. So you'll know you're too superficial if you point up and you can clearly see the internal tip. And if you're too deep, post-septal, you really can't lift up very much at all. And so that's kind of how I distinguish which plane I'm in.
Thanks, Shaw. We've also got a question here from Olivia. She was asking what type of suture that Guy uses for his brow suspension sutures. And I think originally that was described by Bob. And I've been in surgery with both Bob and Guy, as well as Mike and Sean. And I think a lot of the time that's a dissolvable suture. But Bob, you've probably had a lot of experience with this. Can you tell us that brassiere suture, the brow suspension suture, we've got a couple of questions of some of the critical points that you use there, because one of the problems that I've had at the start was sometimes you get a little bit of puckering post-operatively that you need to hold the patient's hand with, I think.
Right. So first of all, in terms of the suture, Angelo, it doesn't make any difference. But
yeah, I know your feelings on the sutures.
Right. I like absorbing sutures anytime they're buried. So, Vicryl ties easily or monocryl or, a suture like that would be good. Now, in terms of the puckering, it does some practice to try to get the sutures evenly across the lid because you're making a pretty powerful connection. If I see a pucker on the table, I take the suture out and try to replace it. But having said that, there's always cases with delicate skin where you're going to get a little pucker. And the good news, I imagine you've found this also, Angelo, is that those puckers do tend to go away over time because settles out. Some of the puckering is just related to the tight early in the suture.
Thanks, Bob. I'd like to ask Mike, with your lower lid fat transposition procedure, I think having worked with you and listening to a few of your lectures, you would very rarely resect any fat. But in some of those patients who have very puffy upper eyelids, sometimes there might be a little bit of sculpting before you reposition that fat apron. Can you take us through how often you actually remove a little bit of fat in the lower lid, if ever?
I rarely remove fat on the lower lid. If I can't find any other use for it, then I'll rarely remove it. But most of the time, I'll try to reposition it because the orbital rim depression in the cheek are such large sinks, so much volume loss that that volume underneath the orbital rim depression, it usually disappears very quickly, even in people with a large amount of prolapsed orbital fat.
Yeah, thanks very much. We've got a fantastic session later on where some of our speakers will be speaking again, and we've got a debate on whether we should approach a good-natured debate on whether we should approach lower lid blepharoplasty transcutaneously or transconjunctivally. And I know that Bob and Mike are smiling there because this is something that we always talk about. But I wanted to throw to our Melbourne studio finally on this occasion and see if Benjamin or Peter had a question for any of the speakers. We've got a couple on the screen, or you can ask some of the things that we were discussing before, guys.
Thanks, Angelo, for remembering us down here in Australia's second largest city. And what great talks from our colleagues in the States.
They can't hear it.
Can you hear anything I'm saying there, guys?
No, they can't.
We can
So
in
just go to
Sydney,
Sean.
but they
Sean,
can't overseas.
Can you hear anything I'm saying? Mike, can you hear anything I'm saying?
No.
No.
I think the guys. We
have
can
to-
hear you. We can maybe transpose
Well,
the
you can
questions to the
relay
guys.
Yeah, relay the questions. Relay the questions.
Yeah, we just wanted to ask Sean, with the downtime after, upper lid blepharoplasty, if he's doing that Accutite work on the lower lid, what's the downtime and what percentage of patients would he do this if he was doing an upper lid bleph, or is he doing it as an independent procedure most of the time?
So that question was for Sean Paul, related to the Accutite device. If you are doing an upper lid blepharoplasty, how often do you do that in conjunction with the radiofrequency heating of the lower lid? And does that change the downtime for the patient?
Yeah, I think it's a great option to keep the patient away from general anesthetic, which can be used for lower lid blepharoplasty for more comfort. So you can take the case and do it under local anesthesia or an IV anesthetic much more comfortably. You can still get some general contouring if you don't want to do any fat transposition during the surgery and they just need skin tightening or they have laxity. Accutite and Morpheus has really changed the way I approach the lower lids. Because you're just getting that general contouring, and downtime wise, the downtime from an Accutite and a Morpheus combined is comparable to an upper blepharoplasty. From a swelling and bruising standpoint, it's a little bit less. And so you're not having the surgical cutting downtime or the anesthesia downtime. So I think it's a great adjunct to upper blepharoplasty.
Angelo, you can tell them we're very happy to see them, even though they can't hear us. But can you ask Sean for me two things we worry about with all of these non-invasive or these non-surgical procedures? One is the degree of improvement, and the second is legacy issues afterwards? In other words,
Yes.
what happens with time and what happens if you have to operate on these people? So,
Gotcha. So it's a good question from Peter Callan in our Melbourne studio. Those guys are very happy that you guys are on board and can hear us. But with some of the energy-based devices, whether that's Accutite, radio frequency, microwave energy, there's a few devices around. One of the questions that Peter was asking was, what percentage of improvement do you counsel the patients to expect, let's say 12 months out? And also some of the legacy issues. We've been seeing a little bit in the literature where perhaps patients that have had 5 or 10 years ago, some of the other high frequency energy devices have had some changes to the subcutaneous tissues and fat and all those plans. And does it make surgery more difficult afterwards? Sean Paul.
These are all great questions and concerns I thought about before adding these to my practice. I think, in particular, these technologies provide a safety monitoring on temperature, so you can control, and it cuts you off if you're overheating the tissue, which is a problem with a lot of the contour deformities you were seeing with some of the earlier devices that were out there. I think from a percentage of improvement standpoint, you have to be very honest with your patient that, I would say 20 to 40% improvement versus traditional surgery is appropriate. We have our first study of 100 eyelid patients that we've done that'll be coming out in the next year, and we'll walk through that, and that sounds about the result that appears to be around the results we're going to get. But the ones that were above that had dramatically improved. We did not, and we had very minimal under corrections. And so, I think, what's that going to look like in 5, 10 years? Well, do we really know how long, traditional blepharoplasty lasts? Well, a lot of the talks I've heard as I've gone through, training and now into practice, everybody's changing their evolution on excisional to more tightening. So I think what fits well with this is you're not removing volume, you're tightening skin. So you're using the natural fat to your advantage, which I like. I think you are trying to not melt fat under the eyes or melt fat in the face. You're trying to tighten the skin. So I think it's a different way of looking at aesthetics. The most important thing I found with this particular technology is the safety profile has been great, and the device is smart enough to help you turn off the device if you're reaching temperatures that are too high. Of course, these are things you want to discuss with your patient in a preoperative setting, and the face continues to age. So is it going to negate the need for a facelift in the future? Probably not. Is it going to negate the use for filler if they have volume loss? No. So all these things need to be discussed with your patient preoperatively. I think the biggest thing I've learned from doing a lot of these treatments is some patients are still better suited for surgery, but certainly they're looking for options, and I think it's nice to have an option.
Could I follow that up, Sean? Have you had any cases where you've done surgery afterwards, transconjunctivally, and had a look at the septum or the site where you've actually done the procedure?
Yeah, I've done about 2 patients that were early patients that I did the Accutite on, who had very, very 4+, very full lower loads of 4+ theta blepharon. And it was a transconjunctival surgery. I didn't see any change in anatomy. I would have expected to see some tightening, and I think that those are patient selection issues when I started. But I think, is there a risk that you're going to have some tightening or fibrosis? Certainly. We're just, in the cadaver lab, we've studied it so much, and we aren't seeing the same type of degree that a traditional cautery would have, and this is just a little bit more of a gentle tightening. So these micro contractions or micro tightenings with radio frequency, I think over the long term, they'll continue to tighten and improve skin, but only to a certain degree. So I haven't seen such a dramatic change to see a retraction or tightening that would need repair later, under treatment, if anything.
Yeah, that's good news.
That's good. So I think with many of the procedures and the devices, one of the most difficult things is to find out what patient they're useful for. At the start of any new device, often we use it on everyone, whatever it is, whether it's a surgical technique or a new device, but it doesn't work on everybody, and everybody thinks, okay, that's no good. But then you get a gradual pickup as your patient selection improves, and you can find which patients it's very useful for. Peter and Benjamin, do you have any questions you'd like us to relay before we discuss?
Yes, I'm not sure if Bob and Mike and Sean can hear me now directly. Can you guys hear me? Hey, okay,
Yeah, we're up.
okay.
Yes.
Two important questions. One's for Professor Goldberg. What were you drinking? It seemed to be like a cloudy rosé. And also, Mike, which beach were you standing on for your first talk?
So that was some kind of sparkling cider, which is all I could find in the refrigerator. But the fellows, you'll be happy to know, Ben, have organized some nice, genuine champagne for this evening, and we'll be enjoying while we watch the meet in Los Angeles in your honor.
Mike,
And hi, Ben. Yeah, that actually, I'm embarrassed to say that's my backyard of my beach house where I've been quarantined for a good part of this time. And actually, you don't see the house because the house is basically a trailer, but the beach is pretty nice.
That's all it takes.
So
Thank
we've
you.
got a good question from Stephen, and it's sort of been my experience as well. Many of the radio frequency devices, a lot of the technology has been developed in Korea. Many of the cosmetic surgery is very popular there, as you know, as is radio frequency procedures. And Stephen asks, in the first 100 patients that you've had experience with, Sean, are there a particular subgroup where you noticed, you know what, those procedures are great? Is it perhaps thicker skinned Mediterranean people, Asian patients, African American patients? Do you have any insight from those patients?
Yeah, I mean, a lot of this will be described in our study, but basically patients who are under the age of 60, as early as 20, have a thicker dermis and just have lower lid. They have a great lateral canthal tendon that's intact. Any sort of laxity, thin skin, those are harder patients to treat. Now, we didn't study the neck region, but certainly in the neck, you have patients who are a bit older that have the crepiness. We're seeing patients there with thinner skin that do really well with the radiofrequency microneedling as opposed to the Accutite or the FaceTite. You kind of need some fullness and thickness in the skin to help contour a younger face. So if you have a patient who's under 50 years old it's not ready for a facelift, or they want submental tightening that's going to have quicker recovery and better results than liposuction alone, those patients do fantastic with radiofrequency added to liposuction or traditional surgery as well. And so I think the combination is critical, but you do need that younger patient. And you'll have patients who come in that are over the age of 50 or 60 that want to try something that's minimally invasive, and FaceTite and Accutite may not be the right choice for them, but it depends on the area they pick. And also you can apply this to the body as well. So if they have crepey skin across their chest or on their underarms or on their legs or their stomach, there's other areas you can use it. But I think in general, you want a patient that's between the ages of 20 and 50, 55, and that's your kind of general area. We don't have a lot of Asian patients that come through my practice. We have a lot of Hispanic patients, Middle Eastern patients, Caucasian patients, and all those patients seem to do very well. What's nice about this device is that it's able to treat Fitzpatrick 5 and 6 as well. So it gives our patients who have darker skin tones an option. We do pre-treat those patients with hydroquinones. We have a protocol for that as well. We've seen a couple cases of hypopigmentation afterwards that have been successfully managed conservatively post-treatment. But I just really think this works well with patients with a little bit thicker skin.
Thanks very much. Well, look, I'd like to thank Mike Groth and Robert Goldberg and Sean Paul for joining us for a fantastic discussion. And to remind you all that at 11, we're going to be joined by some of our guests from Cleveland in the United States, as well as our Pacific Rim colleagues from Singapore and Hong Kong. So we'll see you all back in about 10 minutes at 11:30. Thank you very much.